Hello, everyone. Thank you so much for joining us today. My name is Kristen Portland. I'm the Executive Director of ANID, and I am here with Dr. Kim Dennis, founder of SunCloud Health. We are here today to talk about GLP-1s and eating disorders. This is a really big topic. There are so many things we don't understand, are hoping to understand, that we've been seeing in practice, in support groups, and the peer work that ANID is doing. And we are here today just to ask some questions, try to learn so we can take care of our community. This community Q&A started when Dr. Kim suggested it after Anna was putting together a web page to answer some of the questions that had been coming to us on the helpline in the context of mentorships and in our support groups. And from the number of folks registered and the number of questions that were submitted, I think it was a really phenomenal idea. So just so you know who you're here with today, Dr. Kim Dennis is a board certified psychiatrist, eating disorder specialist, and is board certified in addiction medicine. She specializes in treating eating disorders, addiction, trauma, and complex co-occurring psychiatric disorders. She's a co-founder, CMO, and CEO of SunCloud Health, and is on faculty at University of Illinois Chicago as a clinical assistant professor. And she's just a really cool person. So I am very happy to have her here today. And this was a really amazing idea. So Dr. Kim, thank you so much.
Thank you so much, Kristen and Enad, for hosting this and everybody who's come today. I'll start with just saying if anybody is triggered at all at any point during this, I really encourage you to do whatever you need to do to take care of yourself and your recovery. And I'm just going to start off with a few slides just to sort of give an overview of what these medications are and sort of what's out there and what's not with respect to use of these medications in people with eating disorders or with histories of eating disorders. So let me go ahead and share my screen. Okay, so these medications as a class were first approved in 2005, which is news to a lot of people because we didn't really hear about them until 2021, 2022, when they got plastered all over social media and all over subway stations and buses and everywhere. And they were originally created to help manage type 2 diabetes. And they were sort of found as a side effect that they were associated with weight loss. As these medications were further developed, both the glucose lowering properties as well as the weight loss properties have been sort of engineered to be more and more intense and increased. We know that the GLPs have a multi-system impact involving our GI tract, pancreas, liver, heart, thyroid, bones, and brain. And activity in the brain particularly impacts appetite and reward centers, namely to decrease hunger, to decrease motivation to eat, and to decrease the reward that is associated with eating. As a class, these medications carry FDA approvals for type 2 diabetes and weight management, and also a whole host of other indications, really just in the last couple of years, including, prevention of cardiovascular disease and stroke, obstructive sleep apnea, and it seems as if more and more indications are coming out, by the month. So this is just a slide that shows all of the different systems in our body that these medications impact. And again, there are receptors for the GLP-1 medications in all of these various organs. And this is a list starting from the oldest, which was exenatide, all the way down to the most recent of these medications, tirzepatide or Mounjaro. And these are the areas of the brain that are activated in response to food. So eating is a very neurobiologically complex experience, and it impacts many areas of the brain, not just the reward center or the nucleus accumbens here, but also the habit centers of our brain, the orbital frontal cortex of our brain, which are the areas that we use to let us know what we're attending to in our environment and what's important, what we're drawing ourselves to, and what we're staying away from. Our inhibitory centers of that executive lobe of our brain as well. And there are GLP receptors throughout both the orbital frontal cortex and the reward centers. And there's been, I think at the outset, it's important to just be clear that there's been very little in the way of research about these medications, specifically in populations with eating disorders. And the probably 4 to 5 studies that we do have a very small number of patients total in them, around 130, 140 patients. So that is not a lot of data. And all of those patients, all of these studies have been in patients with binge eating disorder, which leaves out a whole lot of other people with eating disorders or histories of eating disorders. So it's important just going into this talk for, I think, everybody to know that. And ideally, whenever anybody's being prescribed one of these medications, or even one of these being suggested to them, or they're talking to their doctor about it, that's and they have a history of an eating disorder or an active eating disorder, that one of the first things that they hear is, we don't have a whole lot of research to base, risk-benefit analysis on. We know that the common side effects with these medications are GI related, especially at the outset or at dose escalations, and that would include nausea, vomiting, diarrhea, early satiety. Other risks include malnourishment, gastroparesis, which is a slowing down of the muscle contractions in the stomach and in the GI tract as a whole. Constipation is also part of that. These two are things that people with eating disorders oftentimes struggle a lot with, even before even thinking about taking medication like this. Hypoglycemia, pancreatitis, renal failure, dehydration, reduction of muscle mass, which is particularly problematic for older people. There's a risk of certain types of cancer, endocrine cancers, and then diabetic retinopathy. And some of the unique risks for people with eating disorders would be particularly weight loss, whether or not weight loss is triggering eating disorder cognitions and eating disorder distortions, malnourishment. There's concern about for people who maybe have genetic predisposition for an eating disorder, getting on one of these medications and being triggered into a full-blown eating disorder, something we would call iatrogenic eating disorder, or an eating disorder that's caused by a medical intervention. We don't know much about the impact on current eating disorders outside of, again, a small number of studies looking only at binge eating disorder. There is for sure a risk of misuse. I've seen this in my practice. Patients who have no indications for these medications, being able to get them online and getting really, really sick in many different ways because of using these medications. We don't know much about the impact of long-term use. The longest study, I believe, was 4 to 5 years. So this is particularly relevant when we're thinking about children and adolescents and those folks being started on these medications. Generally, these are medications that doctors are talking to patients about being on for life. So I think that's a whole nother conversation when these are being considered or used in adolescents who are in a period of rapid development and rapid growth. There already are increased inequities that we see with regards to who has access to these medications, and racially minoritized people, people in lower socioeconomic status have lower access to these medications. And then there's a lot being talked about what are the impact of these medications on weight stigma and fat phobia, and how does that in and of itself affect brain biology. And there are some real benefits of GLP medications, which I think as an eating disorder field, we need to acknowledge and, learn how to talk about, particularly for people who have progressed type 2 diabetes and cardiovascular disease. So there are some weight neutral benefits, like improved blood glucose, a lower hemoglobin A1C, decreased risk of myocardial infarction or heart attack or stroke in those with cardiovascular disease, decreased cardiovascular mortality. They have been shown in very, very, very large studies to improve survival rates for people who have cardiovascular disease. And then there are a whole host of other areas that I think are still being explored. Obstructive sleep apnea, since the time that I originally created this slide about a year ago, has been shown to be improved with GLP medications. There are people looking at inflammation, neurodegenerative diseases like dementia, fatty liver disease, kidney disease, and addiction. And then, of course, there's weight loss. And is this a risk or is this a benefit? And for whom? And who gets to say? I think the who gets to say part is also critical in this discussion. Ideally, the person who gets to say is a well-informed patient. I think how do you get somebody to be well-informed depends a lot about who's having the conversation with them. And that conversation is going to sound a lot different if it's coming from me as an eating disorder professional than if it's coming from a primary care doctor or an endocrinologist who maybe hasn't had a lot of experience or training in eating disorders. There's been of the few studies that there have been done, there was a meta-analysis that was published this year that looked at 5 studies, particularly specific to binge eating disorder, and showed decreases in the binge eating scale overall. But there's a lot of heterogeneity and mixed results among those 5 studies. So again, I share that to say, like, maybe there's some potential for that. Certainly on a patient-by-patient basis, I've had patients who report that, food noise has gone away. They're able to eat more intuitively. They eat what they like and they stop when they're full. They feel like they can intuitively eat now and they couldn't before. And there are other patients for whom these medications either leave them in a state of malnourishment, leave them in a state of not wanting to continue them because sometimes they can get it from the pharmacy, sometimes they can't. And there's, wide fluctuations in their physiology and in their day-to-day experience when they're on the medication versus off. And there are some patients who should not have access to these medications at all, who unfortunately do. And then I just want to show people when I'm having discussions with patients who want to be on these medications, who have an indication for it, who are stable in eating disorder recovery, there are some real differences between medications with regards to weight loss. We know that dieting behavior is a known risk factor for the development of eating disorders, right? Like that we know, that's pretty clear from a lot of research. So if a patient really wants or needs to be on one of these medications, there are some medications that risk is going to be much higher with. So the medications at the left of this slide, the newer medications have a lot more in the amounts of weight loss than oral semaglutide, which is an oral form of Ozempic, liraglutide, or dulaglutide, some of the older medications. So generally, like one of the things that I think is important to be able to share with patients, and I'm going to stop sharing my screen at this point, is okay, you want to be on one of these medications. Maybe you have, progressed type 2 diabetes with end organ damage. What are some of the medications that are going to be more risky? What are some of the medications that are going to be less risky? And then also dose. Many of the newer medications have pretty standard dosing regimens that always end up with the highest dose. And we never prescribe medications that way. Like Zoloft, for example, the highest dose is usually around 200 milligrams. I have patients that respond to 50 milligrams. I don't continue to escalate them to 100, 150, and 200 every month based on a schedule. And for better or for worse, well, for worse and for worse, this is the way that these medications are being prescribed. And follow-up sometimes is longer than, sometimes follow-ups in 3 months, sometimes it's in a month, sometimes it's in 6 months. There's a wide range in how frequently people are seeing their physicians. So one of the other pieces that I think is critical for anyone with an eating disorder or eating disorder history is like weekly follow-up. And open communication between the eating disorder provider and whoever's prescribing the GLP medication. Because if there's a dose that is less than the maximum dose that a person is tolerating and getting results with improved blood glucose, for example, that would be a dose to stay at rather than to try to continue to escalate or to stay at a dose that clearly is not working. So I will end there with the overview, and maybe we could get started with some of the questions.
Yeah, thank you so much, Dr. Kim. And just so everyone attending knows, the Q&A is open. Please submit questions there. We'll be monitoring and asking throughout. And if you submitted one ahead of time, we will do our best to get to it. I combined some questions that had similar themes. So let's get started. First, there were quite a few questions about screening, how we find out if patients are appropriate for these, and specifically, how can healthcare professionals help detect signs of someone trying to use GLP-1s to partake in eating disorder habits? Are there guidelines or recommendations around screening for eating disorders? And are online prescribers following these?
Online prescribers, first of all, there aren't guidelines yet. I'm part of an international group that is trying to create a guideline for exactly this, to put some guardrails in place for people with eating disorders or eating disorder risk when it comes to prescribing these medications. So as of right now, there are no standards or guidelines that are being implemented, for example, in primary care or endocrinology or family practice medicine. I believe because there's so much overlap between type 2 diabetes and eating disorders, for example, that anyone being prescribed these medications really ought to have at least a SCOFF screener, which takes a minute. There are many other screens that I think would be ideal, the binge eating scale, the EDEQ, the eating disorder inventory. NEDA has an eating disorder screening tool on its website. So I think there are lots of tools that we could be using. And the question is, how do we get this into primary care, which is much, much bigger than our eating disorder field or endocrinology, so that before being prescribed one of these medications, people are being adequately screened. I know the American Academy of Pediatrics has a work group, which I've also been involved with, that's looking at how do we get the word out to pediatricians around screening for eating disorder risk, particularly in pediatric populations.
That's a good segue into another question, which is, what are your thoughts about pediatricians treating obesity in the pediatric population with GLP-1s?
I was really shocked when the latest guidelines came out. It's been at least a year, if not 2 years now, and that GLP medications were included as a tool in the toolbox for pediatric populations because, again, we have no studies whatsoever on any long-term use in adolescents. And there's a lot of concern among pediatricians around growth. This is a time in kids' lives when they ought to be increasing weight and increasing stature. And we don't know a whole lot about what are the longer term effects of being on a GLP medication as an adolescent, for how long, for the rest of their life. And what are some of the developmental side effects that we're unaware of at this point. I think there's a whole lot of risk. So yeah.
Yeah. Are there studies in the pediatric population?
None that I'm aware of.
Wow.
None that I'm aware of.
Okay. Then next, for providers specifically, how can we best support our clients who have a history of disordered eating or eating disorders who are taking GLP-1s?
Yeah. So one of the things that I talk with clinicians a lot about is bias, and if I have bias, I think it does my patients a lot more good for me to own that bias and be explicit about that bias in a trauma. I mean, I think that's, transparency is a good trauma-informed care approach. But one of the best things I could do besides like owning whatever my opinion is about these medications, is one, being educated about them, and looking at data, which I'm not accustomed to. I generally, as an eating disorder professional, hadn't spent a whole lot of time looking at results of obesity medicine trials, but beginning to familiarize myself with that. More importantly, I think, is having connections and conversations with the prescriber, because it does my patient no good. It hurts my patient if I'm sitting in my office saying, this is a really bad idea, or I'm really concerned about all of the risks. And then they go to their endocrinologist who's like, oh, thank God we have a solution for you, putting myself in the shoes of the patient. That's a really sort of dichotomous experience that I think can feel gaslighty to a lot of our patients. So the more I can talk to the prescriber, one, the more that we are going to get our small but mighty eating disorder voice embedded into the rest of the medical field, the more that doctor is going to know about what my concerns are and what some of the eating disorder risks are, and the better they're going to be able to monitor for these as well. So the more we can sort of, talk to other medical providers who are coming from a completely different lens and, have as much of a unified sort of message as we possibly can, the better.
On the flip side of that, what advice would you give to a patient who maybe has some eating disorder or disordered eating history of their own, who's being recommended a GLP-1 for whatever reason? How can they go into this in a way where they can advocate for themselves and make sure their providers are going to talk to each other?
Yep. So I always tell people, one, will you sign a release for this person who you're having the conversation with? Two, does this doctor know that you have an eating disorder history? A lot of times the answer to that is no. Sometimes the answer is yes. And even if the other provider does know, sometimes, they know, but they don't really know what that means. Which again is why me communicating with that other provider is so important. And I think it's just, again, like I want my patients having full informed consent, right? And for me, that means, yes, I'm going to acknowledge the medical benefits and what they are in the way of type 2 diabetes, in the way of cardiovascular mortality, prevention efforts in that arena. But I'm also going to talk about the risks, and I'm also going to talk about all that we don't know from an eating disorder perspective, right? And generally, when I'm giving patients clinical recommendations, I'm basing that on the research, which we have very little of, my own clinical experience in working with patients who have similar conditions, and the patient's preference. So we'll go through each one of those and talk about what are the risks, what are the benefits, and how do they apply to you as an individual. And I think oftentimes we lose, we can lose that focus on the individual. And I know, one of the things that we talk to patients about all the time is bodily autonomy. And this is part of that, there are definitely patients who I do know who are on these medications feel so much shame in eating disorder circles about even sharing that they're on these medications, and that's problematic.
There were a few different questions ahead of the event today, and one in the chat now, which is looking for information on someone recovered from an eating disorder who's on a GLP for intentional weight loss. And a few other questions just kind of relating to what you've been seeing in your practice. Are there people for whom this is absolutely not appropriate, and kind of how to navigate any patients who maybe aren't appropriate but are taking it?
Yeah. Well, for sure, there are patients for whom these medications are contraindicated. And again, I've certainly had patients come to SunCloud after having procured these medications online, or even not online, quite frankly, even like through office visits, or through, my dad's best friend is a nurse practitioner and I got it. They gave me a prescription. So people are definitely having access to these medications, and some people have clear contraindications to being on these medications. Anybody with atypical anorexia, which is almost universally missed in primary care, many times even missed in, eating disorder circles or psychiatry. The other risk category that I think is especially high are people with who live in larger bodies who have non-purging bulimia, who are misdiagnosed as having binge eating disorder, which, again, there's some preliminary data saying that it could potentially be helpful. But for a person with non-purging bulimia, it would probably be, the risks would probably outweigh the benefits. And we don't have any data on bulimia, these medications and their use in bulimia. So if a person, back to the original question, has a history of anorexia or a history of disordered eating, so historical, and now they're taking it to specifically for a weight loss indication, right? Like, is that okay? Is that not okay? Well, it would sure bring up a lot of like red flags for me if you've had a history of anorexia. One, I know that you have the genetic piece of the gene environment interaction that sets people up to have anorexia. So we know that. So we can start to have a conversation about like, what do we know and what don't we know? We know that you have this risk, right? Because you've had anorexia and you've certainly had the metabogenetic makeup that goes into having that. So could that happen again? Sure. We know that part of what triggers anorexia is and sort of propels it forward is weight loss. Do we know if a GLP mediated weight loss is going to do that? We just don't know, because it hasn't been studied. So what we do know are there are risks. Are there health benefits to you? Maybe, maybe not, and being able to at least slow people down and have these discussions, because many people with histories of eating disorders aren't having an informed consent conversation with their primary care doctor about the anorexia that they had 20 years ago or 10 years ago or even a year ago, you know?
Yeah, there's just so much we don't know. I feel like we keep coming back to that the research is just so limited. So
And
on
I just want to say on that front, it's always like I step back from it and I'm like, are there any other medications that feel this sort of like experimental, for people with eating disorders that we've ever used before? I can't think
that
of
are also
any.
getting so much airtime, so much attention. Yeah.
Yeah.
So, okay, in the audience now, Rachel would like to know, can you speak more to prescribing these medications specifically for those with sub-threshold BED or those struggling with emotional eating concerns? And this echoes a lot of the comments or questions that were submitted ahead of time asking about like, are these really helpful in curbing the urge to binge? Will it worsen restrict developments? How to have these conversations?
Yeah.
Yeah.
So could it be helpful for the urges to binge? Yes. Is Vyvanse helpful for the urges to binge? I mean, we have a lot of research on Vyvanse for binge eating disorder, and it shows improvements. Does that mean that every single person with binge eating disorder is going to respond to Vyvanse? Absolutely not. There are plenty of patients with binge eating disorder that I won't recommend Vyvanse to for X, Y, or Z reason, right? So I think, again, we go back to what is your motivation and intention for taking this medication? Do you fully understand what a course of this medication will entail, including like potentially taking this medication for the rest of your life? And can we have a discussion ahead of you even starting the medication about how will we know if this is not working for you or worsening eating disorder thoughts, leaving you in a place where you are malnourished, So sometimes those discussions look like what sorts of like meal plan things are we going to look at and eating behaviors are we going to look at? Like, for example, like if you're not eating one of your meals, right? Would that be a red flag for you? It'd be a red flag for me. And having discussions specifically around, and involving the patient in these discussions, and getting a list that the patient writes down and that I have documented. Okay, these 5 things would be red flags, and we both agree before you starting this medication that if any of these 5 things happen, we're going to take a pause and reevaluate. And let's loop in a support person also, by the way. So it's not just you making these decisions once you're already into an eating disorder mindset.
I love that you're involving the patient there and letting them help choose what those red flags are. And you just keep coming back to autonomy, which I think is really important. Okay, now Phyllis has a hand up and wants to ask a question. So Phyllis, just a heads up, I'm going to allow you to speak and ask your question here. Okay, so you can go ahead and unmute and ask away.
Yes, hi, can you hear me?
Yep.
Yes, okay, so I mean, I hope it's okay to ask this question. I don't want to upset anybody who's listening here, but I'm really picking up on this thing about shame. And I am 76 years old. I have struggled with morbid obesity since I was a child. I have done every possible medical, therapeutic, spiritual, 12-step, every possible intervention. Everything works for a little while, then it doesn't, right? I was diagnosed with binge eating disorder 2 years ago. I actually worked with a mentor through ANED. And so I've been on Ozempic now since the end of January. My doctor prescribed it for me. My blood sugar levels had become pre-diabetic. As a result of being on Ozempic, my blood sugar is normal, my cholesterol is normal, my blood pressure is normal, and I am losing weight regularly, and I'm still on a fairly low dose. But I would continue taking this medication for the rest of my life, even if I never lost weight. Because, and I know that sounds crazy, but what I'm experiencing for the first time in over 70 years is that this voice in my head that tells me I have to eat is gone. And I mean, I get choked up whenever I talk about it. I mean, it's gone. I feel free for the first time in my life. Now I'm still eating, reasonably healthy meals, watching my protein, watching my fiber intake, making sure I'm drinking a lot. My meals are way smaller, but again, aside from the weight loss and the physical, it's the psychological, spiritual freedom, the emotional freedom. But I'm afraid to talk about this because I've mentioned it once in an eating disorder group, and the shame. I'm cheating. Everybody said I'm cheating and it's all emotional. I'm like, what if it isn't emotional? What if it's medical?
Yeah.
I don't know what to do. Well, I don't know. I don't want to abandon my eating disorder community. Maybe
Yeah.
that's not the right thing to do, but oh my God, I'm so grateful for this medication.
Yeah. So first of all, thank you for sharing and thank you for being here today and sharing so openly, especially about shame. And I feel very strongly that, you know, so much of this is biological. We've focused historically in the eating disorder world on the psychology
Yeah.
underneath it. Um, but so much of this is biological. And I believe that I've met two people who have the same exact eating disorder, So if we don't have space in our eating disorder community for people to have different experiences with different treatment modalities, with different medications, with different subsets of the illness, we're really doing a lot of folks a big misservice, and we're going to stay uh, anorexic and small. And I think there really needs to be safe places for people with different experiences to be able to share where they're at and to share what they're doing and to not be met with shame or, scorn or that's triggering for me, so please silence yourself, you know? Um, so are there people for who these medications have benefit? Yes. Are there people for who these medications do a lot of damage? For sure. And can we embrace the dialectic and acknowledge, that there's a whole lot of nuance to all of this, and there's a whole lot of like individuality that needs to go into these decisions and these discussions.
Phyllis, thanks so much for sharing. Um, okay, to follow up with that, and kind of, I guess on the flip side, someone in the audience asked, but what about our patients who are on these medications who don't need to be, who might be getting them online or from their doctor's cousin's friend? How do we support and protect those people?
Yeah, so a lot of times it's, obviously working with the patient, getting an ROI for whoever's prescribing it, even if it is the cousin's, husband's friend, and looping in somebody else in that person's life that they trust, and who cares about them. Um, like I have patients, I have former patients who are reaching out to me because they've gotten really sick on these medications. And it's the same old thing. Like, okay, I think you need to go to a medical hospital. Well, I don't want to go to a medical hospital. I think you need to go to an emergency, so intervening on it is, it's what we do. We intervene when somebody is back into eating disorder, illness, and in this day and age, sometimes back into eating disorder illness looks like, hey, I got a GLP medication. So we intervene in the ways that that we're accustomed to intervening, just associated with a different, a different eating disorder weapon.
Yeah. And backing up to screeners again, Allison Ward is asking, what recommendations do you have if a patient scores positively on a screener for eating disorders, or it is learned that a patient has a remote history of an eating disorder? What would you recommend a provider do RE prescription GLP-1s, especially if there is no behavioral health provider in that clinic where the patient is being seen?
Yeah. So if somebody screens, I guess there's two questions. If somebody screens positive, that's somebody who really does need to be referred for an evaluation by an eating disorder specialist, so that you as a prescriber have, the knowledge that you need to have, again, in order to have risk benefit conversations with the patient. Assuming that you are not a prescriber who is an eating disorder, you're not a SEEDS, right? You're not an eating disorder specialist. If it's somebody who has a history, and I would do that, by the way, before prescribing a GLP, if somebody screens positive. I would have a conversation with that person, like this evaluation needs to be done before we can make a true informed decision about whether or not this is going to be helpful for you or harmful for you. And if we don't know, it's important for you to know going in what the potential harms and what the potential benefits are. If it's somebody with a history of an eating disorder, I would, and they have an actual indication for being on one of these medications, I always believe that they need to receive a screener at every follow-up visit, and they need to be followed up with way more frequently than a person that doesn't have an eating disorder. So if your general practice is to see people back in 3 months, or even like a month, I would see a person who has a history of an eating disorder every couple of weeks, or have them see your nurse or a physician's assistant in your practice every couple of weeks, so that if concerns do arise, you're not waiting until 3 months in to intervene, or 6 months.
Allison actually has a hand up, so I'm going to allow her to talk and follow up on that question. So Allison, you can unmute and go ahead.
Thank you. Thank you. This is my question comes from the fact that I currently work in an adult diabetes center as a psychologist, and I know that some providers wouldn't be keen on using a screener for an eating disorder, or having may not feel confident about having conversations with their patients about current or previous eating disorders. And so that's that's kind of where my question came from, because I'm sure they would be wary of having even going in that direction with a patient for fear of Pandora's box and where do we stand this person. And so as a result, my concern is, I have no evidence of this, by the way, but my concern would be that these questions aren't going to be asked because they either don't know what to do with it, or aren't confident in doing it.
Yeah. That's exactly. Sorry.
I said because it's not part of their education or their training.
Yeah. So I think there's, one of the things that I enjoy doing is doing eating disorder trainings for medical trainees, or even, departments at hospitals of fully trained doctors, because there is a real absence and dearth of eating disorder training. And that's exactly my experience, Allison, is that when I talk to other medical providers about why are you not screening, or how do you feel about screening, almost universally the biggest barrier is like, I don't know what to do if I get a positive screen. So I'm like, okay, so then let's just stick our heads in the sand about it, you know? But we can start to talk about, okay, well, ANAD, there are resources that can help your practice connect to resources in the community. You know, in some areas, I think telemedicine is, this is one of the benefits of telemedicine, is that there are people even in rural areas or remote areas that can actually connect to an eating disorder professional now. So that when PCPs or endocrinologists do have concerns, they can develop some connections with therapists, dietitians, psychiatrists who have the expertise in eating disorders and who could say, hey, here's my consultation, here's what I think this person actually has, and here's the risk, here are the risks as I see them. But there's no infrastructure right now, you know, and I think that's something as a field that we need to be a part of building.
Thank you. I really appreciate it. Yeah, I would like to be able to help my colleagues as much as possible in terms of working with patients who have eating disorders and diabetes.
Yes, such a need. Such a need. I mean, it'd be great to have an eating disorder professional in every diabetes clinic and in every weight management clinic. But we don't have that yet.
Yes, and thank you, Allison. Okay. Then to bring up the next one, and this was a question that was submitted ahead of time, but it really jumped out at me. Can interoception be improved while on GLP-1s? Specifically, this person was wondering about hunger, fullness, and satisfaction, and how do we support and foster body trust when clients are experiencing reduced hunger cues?
Yep. So I think it depends on who the client is, you know, and we heard from somebody who is on one of these medications, who has had an eating disorder for a long time, who actually just shared with us that she now experiences, it sounds like, a lot more body trust and a lot more connection to hunger and fullness and freedom, right? So I think it depends on who the patient is. And for sure, I've had patients who start on a GLP medication and say for the first time in their lives, they feel like they know when they're hungry and they have fullness, and they've never had fullness cues before. So yes, that is possible. And I think that's, you know, that's something that we don't really like start with, you know, in our risk benefit as an eating disorder professional. I don't lead with, hey, you know, it's great that you're considering one of these medications, because there are some people who, you know, who actually for the first time in their life ever have hunger fullness cues and feel like they can eat intuitively. But I think that's biological for some people, you know, and I think part of what this medication does for that subgroup of people is to adjust that reward center and its connection with the prefrontal cortex and its connection with the hypothalamus, which modulates hunger, in such a way that people are, you know, hungry, they have a meal that they enjoy, they're able to stop when they feel full, and then they go live their life until it's time to eat again.
For those folks, the folks who are having great results on these medications, how would you advise they get ready if they ever need to come off? And on the flip side, how can providers help prep their patients? Because as we talked about, these are drugs that need to be taken long term to be effective. And like we saw not too long ago, there can be shortages. And how can people take care of themselves? I don't think drugs are ever a standalone solution. So what else can be happening?
Yep. So always, you know, this is why I think it's important for us to make spaces in our support communities for people who are taking these medications, spaces that are free of shame, is because that kind of connection and community is not something a GLP can give you, right? And that needs to remain a staple of good self-care, right? But there is no real answer to that question, Kristen. You know, like we don't nobody knows how to get people off of these medications, or like what the time frame should be. The standard right now is these are chronic medications for a chronic condition, right? Like statins might be if you have high cholesterol. And one of the realities is I think up to 50% of people who start these medications decide to get off of them after a year because either they don't like the side effects, they haven't been able to get it consistently. It shuts off like pleasure to such an extent that they're not even enjoying eating food. So there are a lot of people who don't want to take something for the rest of their life, who just are sort of philosophically opposed to being on a medication for the rest of their life. And for people who are willing, there's the risk that, it's not available next month. I think the shortages have improved as we've sort of come out of 2023, 2024. But that was really dysregulating for a lot of people who are on these medications, particularly those people who have had eating disorders. So we don't, there isn't really a well-established off-ramp, but I do believe that community support, the ongoing, trauma healing, the ongoing sort of biopsychosocial spiritual healing aspects, the GLPs are the bio part of this. So there are all these other aspects of good care that also still need to stay in place.
Yeah. And just quick housekeeping, there are a lot of questions coming in and a lot more that were submitted ahead of time. We are absolutely not going to be able to get to all of them, but I'm trying to pick out some themes to answer as much as we can. But I just want to take a minute to notice that there were quite a few folks thanking Phyllis, sharing similar experiences, and I really appreciate you bringing that up today. And the recording will be available later for those folks who were asking about that.
May have to have a round two.
I know there's just too many questions. This is a huge topic, way more than we can completely cover in a 1 hour thing, but okay. So there were a lot of questions about whether GLP-1s were appropriate for X type of person. So I just want to bring a couple of those forward. And one of the ones that people asked about a few different times is whether you feel they would be appropriate for someone post-gastric sleeve surgery.
Well, they are certainly being used for people post-gastric sleeve, post-bariatric intervention, as a way to sort of improve the results of those interventions. I don't know enough about the research on what those results are looking like, but they're definitely being used in that manner. But again, I would have to do a PubMed search to really look at the research.
Yeah. And what about folks with a history of eating disorder and atrial fibrillation?
Yeah, so there's actually a study that came out just this last week showing that these medications look like they improve atrial fibrillation recurring after somebody's had treatment for AFib. So I don't think there's a contraindication again with having had a history of AFib or having AFib. I think there's again, the conversation around you've had a history of an eating disorder, what exactly was the eating disorder? Do you still have any symptoms of that eating disorder now? How long has it been? What would some red flags be if this were to recur? And we don't have, we just don't have studies on people with histories of eating disorders being on these medications.
Yeah. Okay. Then to flip it again, Greta would like to know, what do you think are the biggest gaps in research in terms of GLP-1s and their impact on people with eating disorders? What direction should the research be heading
in? For sure, it would be really good to have some longer term data on people who have histories of eating disorders who have been, because I gotta believe there are people, like there's a population of people with histories of eating disorders who are now on these medications. And it would be really nice to know how those folks are doing. So that I think is one huge gap. Adolescence is another huge gap. And then eating disorders, certainly more research on binge eating disorder, and longer term follow-up than 6 months or a year. And people who have other eating disorders besides binge eating disorder, like, you know, all of the people who have, I don't know that actually a study on somebody with atypical anorexia using a GLP medication would even get an IRB approval, you know, because I don't know how you could even argue that that would not do potentially a whole lot more harm than good. But for people with bulimia nervosa, who have another indication to be on one of these medications, it would be good to know, you know, what happens in that type of situation as well.
And then I think longer than 6 months was another key piece you mentioned in there too. Yeah, especially for these long-term medications.
Yeah. You have to be on it for life, but we only know what happens for the first 6 months. Good luck.
Good luck after that. Yeah. Okay. Then switching tracks again, there are so many questions, but this is one that came up at least 3 or 4 times. But there's a couple of people who want to know if have the patients you worked with who these meds are not indicated for reported feeling addicted to them? Is there any research being done on possible addiction factor for anorexic patients on these medications? And a few different people have asked about this, the potential for addiction. And there were even 1 or 2 people who mentioned that they had heard from patients about them feeling a high as well. So just wanted to bring that to us.
Yes, for sure. I mean, it's interesting because they're being used and they look to be beneficial for alcohol use disorder, for example. So they're being like used and studied as anti-addiction meds. And I'd like to say that like most things in the eating disorder world are like opposite day of the rest of the world, you know? And anorexia, I think that's like particularly true. And I for sure have had patients with anorexia who are stable and then get on these medications and describe exactly that. Like, I feel like this would be, you know, the words that they use are like, I feel like this is what heroin must feel like to somebody who has an opioid use disorder. And I don't know that that's an addiction to the GLP medication. What I do believe it is the high that a person with anorexia experiences based on the, you know, the metabolic milieu that their brain is exposed to when they're starving and when they're losing weight. So I think it's more of the high feels like I feel high and my brain feels like it's on like turbocharge when I am not nourishing myself, which is part of the metabogenetic biological aspect of anorexia that we don't spend a whole lot of time talking about in our field. You know, we spend a lot more time again talking about the sociocultural aspects, the psychological aspects, but I believe this is biological.
Okay. We are 1 minute out, and I don't think any of our remaining questions can be done justice in a single minute. But I just want to take this minute to thank you so much, Dr. Kim. This is a huge topic. It is not going away, and we absolutely did not answer all of the questions here today. But I hope that we answered something for everyone who attended. We will be sharing this recording on the website, and we will be coming up with a downloadable Q&A as well, and we'll try to see if we can answer a few more of these in some other ways, but ultimately, thank you. This was a great idea. I am really happy that we were able to be here today.
Wonderful. Thank you so much for having me and for everyone coming and asking such great questions.
Yeah. Okay, if we didn't get to your question, I'm so sorry. Maybe we'll talk about a part 2. Okay. Then everyone, thank you so much. Have a wonderful Monday, and the recording will be sent out shortly. All right. And thank you again, Kim.
Yep.